Dr. Vinay is on mute. Sir, you are on mute. Shivam Shah, am I audible?
Yes, Dr. Vinay, please go ahead.
Yeah. So we were talking about the checking the progression of chronic kidney disease. So, yeah. So, first of all, if we talk about the definition of chronic kidney disease, so disease is there for more than 3 months, and whether it is the GFR is less than 60 ml per minute for more than 3 months, or if you have other evidence of kidney damage, that may be in the form of pathological damage, like if on biopsy, if you are finding some fault, if on the basis of radiology, yeah. So now I think I can share my screen.
Yes.
So we were talking about CKD. So definition of CKD is presence of kidney damage or decreased kidney function for 3 or more months. So time limit is 3 months, whatever may be the cause. So criteria is duration more than 3 months, glomerular filtration rate less than 60 ml per minute per 1.73 meter square body surface area, or any evidence of kidney damage, which may be the structural abnormality or functional abnormality other than decreased GFR. So what we mean by kidney damage? Kidney damage may be pathological abnormality, whether it is established by renal biopsy, imaging studies. For example, a patient of polycystic kidney disease on imaging is a patient of chronic kidney disease. Or if you have various markers like urinary marker, if you have urinary sediment abnormality, presence of proteinuria for more than 3 months, that means the patient is CKD. So not only GFR, if you have evidence of kidney damage on the basis of pathological abnormality, and these pathological abnormality are established on the basis of biopsy, imaging study, and other blood or urinary markers. So how we classify chronic kidney disease? We have various staging of patients who meet the definition of chronic kidney disease, starting from stage 1 to stage 5. Stage 5 is the stage of kidney failure when the GFR is less than 15, or what we call end stage renal disease. End stage renal disease, you can say, is a clinical term. That means the survival of patient is not possible without renal replacement therapy, and that renal replacement therapy can be either dialysis or transplantation. So starting from stage 1, where the GFR may be equal to 90 or more than 90. Then stage 2, 60 to 89. Stage 3 is divided into 2, 3A and 3B, with GFR ranging between 45 to 59 and 30 to 44. Stage 4, 15 to 29, and stage 5 is less than 15. Along with that, if you have persistent albuminuria, you have category A1, A2, A3. A1 is normal or mildly increased, A2 is moderately increased. Previously, we used to have the term microalbuminuria or macroalbuminuria or overt proteinuria. Nowadays, we say moderately increased proteinuria and severely increased proteinuria. So if the albuminuria is between 30 to 300 milligram per gram, it is moderately increased. And if it is more than 300 milligram per gram, it is severely increased proteinuria. So talking about the prevalence, we know that now CKD is highly prevalent. Various studies have shown the prevalence ranging from 6% to 10-12%. That means the disease is now widely prevalent in our country. What are the various risk factors for CKD progression? As we have already discussed, once the disease has occurred, once we have labeled the patient as chronic kidney disease, we cannot reverse the disease. We can just slow down the progression. So what are the risk factors for progression? Certain factors are non-modifiable and certain factors are modifiable. Non-modifiable, which are not under our control, the age of the patient, the sex of the patient, low number of nephrons from the birth, low birth weight baby, racial and ethnic peculiarities. So these are the non-modifiable factors which we cannot modify, but we have modifiable factors, and if we act on these factors, we can check the progression. So what about the blood pressure? What about the proteinuria, uncontrolled blood sugar level, obesity, metabolic syndrome, lipid levels, lifestyle, smoking, anemia, metabolic acidosis, pregnancy, disturbed calcium phosphorus metabolism, secondary hyperparathyroidism, and the diet of the patient. So these are the modifiable factors. So if we act on these factors, we can check the progression of disease. So how to manage a patient of CKD? In our nephrology practice, we see patient of CKD. In urology practice, we see patient of CKD. Even our primary physicians, many times they see patients of CKD. As we know that now the diabetes is the leading cause of CKD, almost 30 to 40% patients of our CKD are having diabetes. That's the etiology. So almost every doctor will come across a patient of CKD and he has to manage a patient of CKD. So the points of management are first to retard the progression to end-stage renal disease. As Professor Shivam had told that when these patients progress to ESRD, only renal replacement therapy is there, which is very expensive. Then we know that our patients of CKD, they are more prone to cardiovascular disease. The most common cause of mortality in CKD is cardiovascular. Even our post-transplant patient, they die because of cardiovascular reasons. Many of our post-transplant patients, they die with functioning graft. Their graft may be functioning normally, but they die because of the cardiovascular reasons. And then you have to treat the complications of CKD, the consequence of CKD and uremia, like anemia, metabolic bone disease, acidosis, and we will discuss all these things one by one. So what are the strategies? First is treatment of acute factors. This is very important. Many times we have acute on chronic kidney disease. A patient is having baseline chronic kidney disease, and on top of that, he develops acute decompensation. So any acceleration in the rate of decline should prompt the treating doctor to look for superimposed acute or subacute process that may be reversible. So if you treat these acute factors, the GFR may improve. So these factors may be volume depletion. For example, a patient who is already having chronic kidney disease develops diarrhea dehydration. So there will be sudden fall in GFR, uncontrolled hypertension that will lead to the rapid progression of disease, urinary tract infection, and obstructive uropathy. These two are important from the urology point of view. So a patient of CKD has now developed new obstruction or there is urinary tract infection. So any infection in body will act on the kidney and lead to progression of disease. Exposure to nephrotoxic agents. This is very important. Many a times we see the calls and references from other units, other departments, and we find there that the CKD patient is exposed to nephrotoxic agents. These nephrotoxic agents may be in the form of antibiotics like aminoglycoside. These nephrotoxic agents may be in the form of analgesics like non-steroidal anti-inflammatory drugs. And then sometimes there can be reactivation or flare of the original disease, which has led to the CKD like SLE or lupus nephritis or vasculitis. So these are the acute factors, and we all should know these factors. And whenever patient comes to us with sudden deterioration in GFR, we should look for these factors. Then blood pressure control is very important in these patients because we know uncontrolled blood pressure will further lead to progression of disease. So if we look at the renin-angiotensin-aldosterone system in the kidney, we know that from angiotensinogen to angiotensin 1 acted upon by the ACE leads to angiotensin 2, and angiotensin 2 is known as the murderer molecule. This will lead to sympathetic activity. It will lead to tubular sodium and chloride reabsorption, water retention, edema. It will cause arterial or vasoconstriction. It will act on pituitary gland, and ultimately there will be increased aldosterone secretion. Again, aldosterone will lead to salt water reabsorption, and the end effect will be salt and water retention, increased circulatory volume. So this will lead to the progression of disease. This will lead to the rise in blood pressure also. So control of RAS system is very important in checking the progression of disease. So we have various RAS inhibitors, whether it is the ACE inhibitor or angiotensin receptor blocker or aldosterone antagonist or direct renin inhibitors. So all these drugs will act on the RAS system, will control blood pressure, and will check the progression of disease. So these are the various guidelines and recommended PP targets in CKD. Most of the time, as we follow the KDIGO guidelines, it is less than 140/90 in all the patients of CKD. But if you have persistent proteinuria or overt proteinuria or significant proteinuria, which means that the proteinuria is more than 1 gram in 24 hours, you should try to achieve a lower blood pressure. So this is the, in nutshell, the cause for blood pressure in chronic kidney disease. You have the sympathetic nervous system activation, you have the RAS system activation, you have the salt retention, sodium retention, and the dysregulation of the blood pressure or the autoregulation. So hypertension is difficult to control in CKD patients compared to non-CKD patients. You must have seen that our patients of CKD, they require at least 3-4 antihypertensive drugs from different classes. So treating only one aspect upregulates other counter-regulatory mechanism. Therefore, multi-drug therapy is preferred. So if the patient is having salt and water retention, you would like to give diuretic. For RAS system activation, you would like to give RAS inhibition. Then you have to take care of the sympathetic nervous system also. So why RAS inhibition? If you use any RAS inhibition, remember there will be some rise in serum creatinine because it is the physiological action of the drug. Whenever any patient of CKD comes to you and you start the patient on ACE inhibitor will act on the efferent arteriole. It will dilate the efferent arteriole, thereby reducing the intraglomerular pressure. And by reducing the intraglomerular pressure, there will be some fall in GFR. So some rise in serum creatinine will be there. So rise up to 20-30% is permissible. But if rise is more than that, then you have to look for other factors. There may be bilateral renal artery stenosis. Many times our practice is that, for example, patient comes to us with a creatinine of 2. We start the patient on ACE inhibitor, and next time patient comes to us after say 10-15 days and creatinine is 2.2. we are afraid that now the creatinine is rising and we shift the patient to some other antihypertensive group like calcium channel blocker. But remember, 20% increase is permissible. This is the physiological effect of the drug. We should continue with the RAS blockade because it is renoprotective. It will reduce the proteinuria by reducing the intraglomerular pressure. It is anti-fibrotic, anti-proliferative. It is good for the heart also. It will check the cardiovascular morbidity and mortality also. So RAS inhibition is the drug of choice for early CKD, mild to moderate CKD. And what about among ACE inhibitors or ARBs? We have seen that there are lower rates of discontinuation with ARB as compared to ACE inhibitors, because with ACE inhibitors, you can have some complication like dry cough. What are the other anti-proteinuric therapy? First of all, why we are worried about the proteinuria? Remember, proteinuria is not only a diagnostic marker, it is a prognostic marker also. So if your patient is having more proteinuria, progression of disease will be faster. So if you have two patients of CKD, both of them are having say creatinine of 3, but one patient is having proteinuria of 10 gram in 24 hours, other is having proteinuria of 1 gram in 24 hours. Patient with 10 gram proteinuria will progress faster. So we have to control the proteinuria. So after RAS inhibition, what are the other drugs? If you are using calcium channel blocker, you should prefer non-dihydropyridine calcium channel blocker because they are also anti-proteinuric. Then you have to reduce the salt intake. Salt restriction is important in these patients. And then you have the other drugs like aldosterone antagonist. Then what about the calcium channel blockers? Most of the time we use calcium channel blocker as the antihypertensive drug. There are various types of calcium channel blocker, various types of calcium channel like L channel, N channel, T. So L is on vascular smooth muscle and heart, N is at nerve endings, T is located in kidney also, so in adrenal gland also. So now you have various newer calcium channel blockers which act on various types of channels. So if you can combine a drug which can act on L and N or L and T, so you will take care of various other side effects also. So this is the diagram of glomerulus. You have afferent arteriole, you have efferent arteriole. So T-type channels are present on the efferent arteriole. So any drug which is acting on the T-type channel will lead to the action on efferent arteriole also and will check the progression of disease. So if the drug is acting only on L-type, it will increase the reflex tachycardia. It can cause peripheral vascular dilatation. For example, if the patient is on nifedipine, amlodipine, we know that many of these patients present with the ankle edema. But if you are using a drug which is acting on the T-type channel also, there will be decrease in heart rate, there will be decrease in glomerular pressure, and it will decrease aldosterone secretion also. So how to select any anti-hypertensive drug in CKD? If there is proteinuria, early CKD, prefer RAS inhibition. Then if it is not controlled on RAS, you can combine it with calcium channel blocker. You can use diuretic if there is salt and water retention. Beta blockers these days are not preferred as the first line antihypertensive in CKD. But if you have compelling indication, like if there is angina pectoris post-MI, then you can use beta blockers. Then if there is heart failure or decreased LV ejection fraction, RAS inhibition is preferred. For peripheral vascular disease, diabetes, in diabetes you prefer ACE inhibitor, ARBs, but in asthma, COPD, you will avoid beta blocker. Then in our post-transplant patients, because we know these patients are taking CNI or calcineurin inhibitors, and CNI are known to cause vasoconstriction. So we prefer calcium channel blockers because calcium channel blockers are vasodilator and they will reduce the CNI-induced hypertension also. So after proteinuria reduction in patient of diabetic kidney disease, glycemic control is very important. Remember, some part of insulin is metabolized through the kidney disease. So whenever there is drop in GFR or creatinine level is high, chances of hypoglycemia is always there. So we have to use short-acting insulins. We have to use safer hypoglycemic drugs. We have to use hypoglycemic drugs in low doses. So glycemic control is important, but remember, once the patient has progressed to over diabetic nephropathy, control of blood pressure becomes more important than the glycemic control. Then you have to look for the lipid lowering therapy. You can use statins. So statins can be used, but you should avoid the toxic combination in patients of CKD because the chances of muscle injury is always there. So statins can be combined with ezetimibe, but the toxic combination, for example, combination with fibric acid should be avoided in patients of CKD, and you should use lower doses of statins in patients of CKD. Then treatment of hyperuricemia is very important. Most of our patients, because of drop in GFR, will have increased level of uric acid, and increased uric acid is known to lead to progression of disease. In our patients of gout, you can have CKD, but the important thing is sometimes there can be no relationship between hyperuricemia and progression of kidney disease, but some trials have shown conflicting results. Some studies in IgA nephropathy have shown that hyperuricemia will lead to further progression of disease, and there is twofold increased risk of developing new onset CKD in patients of hyperuricemia. So now the question should not be if, but rather when patients with hyperuricemia should be treated. Now it is clear that we have to treat the patients with hyperuricemia, but what about the asymptomatic hyperuricemia? When to initiate urate lowering therapy in patients with asymptomatic hyperuricemia? Now the consensus is around that if the serum uric acid level is more than 9, it carries a threefold risk for kidney disease, but still further studies are needed to substantiate this. Then lifestyle modification is important. Smoking is known to cause progression of chronic kidney disease. So smoking cessation should be advised to our patients of chronic kidney disease. Several observational studies, they have highlighted the nephrotoxic nature of smoking. Chronic smoking increases the risk of proteinuria, and it accelerates the rate of decline of GFR. Studies have shown that quitting smoking slowed down the CKD progression. Then avoiding nephrotoxic drugs. In the beginning also, we talked about the nephrotoxic drugs. So all nephrotoxic drugs should be avoided. Over-the-counter drugs. Many of our patients, they go for indigenous drug, over-the-counter therapy, some Ayurvedic drugs with toxic combination, with heavy metals. So these should be avoided. Non-steroidal anti-inflammatory drugs, like the drugs from the group of ibuprofen or diclofenac, because non-steroidal anti-inflammatory drugs will reduce vasodilatory prostaglandins, increase vasoconstrictory prostaglandins. Non-steroidal anti-inflammatory drugs can cause acute interstitial nephritis. So these drugs are nephrotoxic. These should be avoided. If you want to use the drugs for pain, you can use paracetamol, you can use tramadol, but non-steroidal anti-inflammatory drugs should be avoided. Then among the antibiotics, we know aminoglycoside are known to be nephrotoxic, so we should use these drugs judiciously. Then certain antifungal drugs, amphotericin B. Radio contrast is very important. We will discuss about radio contrast in detail. And then you have to do the dose adjustment for these drugs according to the level of GFR. Most of the time for the loading dose, no dose adjustment is required. No dose adjustment is required for drugs that are more than 70% eliminated by extrarenal route. But for those drugs where the route of excretion is through the kidneys, the modification of dose is required. So what about contrast? In our urology practice, we use contrast enhanced CT scan, we use intravenous urography. So most of our patients are subjected to contrast. So before subjecting any patient to contrast, it is always advisable to get the renal function test done. And if patient is going to receive iodinated contrast media, we should follow this algorithm. First of all, we should calculate the eGFR based on the equations. And if eGFR is more than 60 ml per minute per 1.70 meter square surface area, no further measures are required. But if the eGFR is less than 60, certain drugs are to be stopped before subjecting the patient to the contrast. Many of our diabetes CKD patients are having coronary artery disease also, so they are subjected to coronary angiography also. This holds true for those patients also. So drugs to be stopped 2 days before and then you have to reassess 2 days after the procedure. Non-steroidal anti-inflammatory drugs, metformin in patient of diabetes, diuretics if we can stop, ACE inhibitors, ARBs, there is controversy, but if you can reduce the dose or stop a day or two prior to the procedure, it's always better to stop and avoid iodinated contrast for next 72 hours if feasible because of the additive dose. Then how to prepare these patients for contrast? Hydration is very important. How to hydrate these patients? You can use either isotonic saline or you can use sodium bicarbonate. If you are using isotonic saline, start in the dose of 1 ml per kg per hour, 12 hours before the procedure and continue for 12 hours after the procedure. So 1 ml per kg per hour isotonic saline, 12 hours before the procedure and continue for 12 hours after the procedure. And if you are using isotonic sodium bicarbonate, how to prepare isotonic sodium bicarbonate? Take 1000 ml of D5, remove 150 ml, add 3 ampoules of 50 millimole sodium bicarbonate, and this solution can be given at the rate of 3 ml per kg per hour, 1 hour before procedure, followed by 1 ml per kg per hour for next 6 hours. So hydration is very important. And then you can consider giving N-acetylcysteine to these patients because N-acetylcysteine is known to be free radical scavenger and contrast is known to cause free radical injury. Contrast is known to increase endothelin. Contrast is known to cause vasoconstriction. So giving contrast to a patient of CKD is very important and we should be extra careful while subjecting these patients to contrast. Then after nephrotoxic drugs, we mentioned lifestyle changes. What are the various lifestyle changes? Weight reduction is very important because obesity itself contributes to CKD progression. Obesity is known to cause glomerular diseases also. Obesity is known to cause focal segmental glomerulosclerosis. So obesity will lead to glomerular hyperfiltration. It can cause secondary type of focal segmental glomerulosclerosis. So it has been shown that exercise and weight reduction, they slow the progression of chronic kidney disease. Then diet is very important to our patients of CKD. Salt restriction is very important to control the blood pressure. And then the diet, low protein diet, 0.8 gram per kg per day in patients of CKD is advised. Along with protein, we are worried about the potassium. So for potassium, we have to avoid the citrus fruits, fruit juices, coconut water. Along with that, if you are giving protein, you can give A quality protein, you can restrict B quality protein. B quality protein in the form of dal, besan, chana, mungfali, butter. So these are type of B quality protein. You can reduce the B quality protein. You can supplement with A quality protein. A quality protein can be in the form of egg white or milk product. So milk and milk product in the, you can say up to 400 ml to 500 ml per day is allowed. So if you are curtailing weak type protein, you can compensate it with A quality protein. Along with that, you have to take care of the sodium, potassium, calcium, phosphorus, and other trace elements also. Taking care of phosphorus is also important. As we know, whenever there is fall in GFR, there is phosphate retention in the body, and this phosphate can lead to the secondary hyperparathyroidism also. So for reducing phosphorus, you should leach out the vegetable. What you can do is you can boil the vegetable in water, then you can throw away the water and then cook the vegetables so that the phosphorus and potassium is removed from the vegetable. Then there are certain fruits which have less potassium. Seb, papita, jamun, ananas, nashpati. These 5 fruits contain less potassium. So these can be advised to patient of CKD in limited amount. And after that, avoiding pregnancy. We know that pregnancy accelerates decline in GFR and it can sometimes precipitate dialysis in the patient of CKD. So pregnancy should be avoided if serum creatinine is more than 2.5, if the patient is having uncontrolled hypertension, or if the patient is having heavy proteinuria. So in these 3 conditions, it's always better to avoid pregnancy. Then in pregnancy, you should use the safe drugs. Nephrotoxic drugs should be avoided. Like ACE inhibitors, ARBs as antihypertensive drugs should not be used in pregnant female. So this is showing the maternal renal outcome according to pre-pregnancy serum creatinine level. If serum creatinine level is less than 1.5, the permanent loss of GFR is seen only in less than 10% of the women. But greatest risk is there if the GFR is less than 14, and along with that, if you have heavy proteinuria. So major determinant of end-stage renal disease progression in these patients are uncontrolled hypertension. So that will lead to 4% risk of preeclampsia if baseline proteinuria is more than 500 milligram per day. And if the creatinine is more than 2.5 milligram, straight away there is progression to end-stage renal disease, which is highly likely during or soon after the pregnancy. So pregnancy should be avoided. Or if the female has become pregnant with creatinine more than 2.5, termination should be advised. If the creatinine is between 1.5 to 2.5, in up to 30% of the patient, there will be decline or permanent loss of GFR, and it will be increased to 50% if along with creatinine of say 2, if the patient is having uncontrolled hypertension, and 10% of these patients will go to end-stage renal disease soon after pregnancy. Remember, some patients of AKI also, they go into chronic kidney disease. So AKD, 5% patients will not recover. Many times we think that the patient of AKI has recovered and gone home, but if you see the concentrating ability, that ability is lost in many of these AKI patients. So thank you very much for your kind attention. So we have discussed about the progression of chronic kidney disease. The important factors are control of blood pressure, checking proteinuria, avoiding nephrotoxic drugs, lifestyle modification, taking care of diet, and along with that, once the patient has progressed to the chronic kidney disease, we have to take care of the other complications also. For example, if patient is anemic, you have to take care of the anemia. For anemia, iron therapy is there. Iron, we have oral iron, IV iron. Along with that, we have ESAs, the erythropoiesis stimulating agent. We have erythropoietin, we have darbepoetin. Now we have long-acting Mircera also. So taking care of anemia is very important in these CKD patients. Then you have to take care of the calcium, phosphorus, IPTH. So you have to look for the calcium phosphorus product, calcium multiplied by the phosphorus. If this product is more than 65, you have to take care. You have to use the phosphate binders. Previously, we used to have the calcium containing phosphate binders. Now we have non-calciumic phosphate binders also, like sevelimer carbonate. And we have the added advantage of sevelimer carbonate. We have various pleiotropic effects also. Sevelimer takes care of the lipids also. So in CKD patients, then you have to take care of the anemia. You have to take care of the other complications also. You have to look for the acidosis. You can look for the ABG. You can look for the serum bicarbonate. And if acidosis is there, you have to use sodium bicarbonate. And using sodium bicarbonate will also lead to checking the progression of disease. Thank you.
Thank you, Dr. Vinay. It was a really enlightening on how to check the progression of the disease. So before I open up the session for all our residents and all faculty and all those who have joined us on Zoom or YouTube, so you are all welcome to put your queries in the chat box. So we will take up these queries if there are any. Before if there is no query at present, I would ask, you told about the radio contrast. I think that's very important because many of us patients do have a borderline creatinine, and then we have to actually get a imaging study in these patients. So at what creatinine level you think even the hydration and all these would not work and you would not allow contrast agents?
So it depends upon the indication also. Many times, for example, a patient of diabetic CKD is having angina and coronary angiography is needed, then we have to put the heart first before the kidney. So even if the creatinine level is high and there is compelling indication, we have to go for the contrast in those patients. But then we can use the minimal quantity of contrast. We can use the isoosmolar contrast. So type of contrast is important. Quantity of contrast is important, and avoiding other nephrotoxic drugs simultaneously and taking care of hydration is important. So if the GFR is more than 60, we are not worried about the contrast. But if the GFR is less than 60, we should take adequate precaution. But remember, if there is compelling indication, whatever may be the level of creatinine, we can and we have to use the contrast, for example, in cardiac situations.
Right. So in cardiac situations, you think you can, you have to use it. And would you like to use N-acetylcysteine in almost every patient?
Yes. Now the studies have shown that it has not a definite role, but still, if you can use, there is no harm. You can start a day or two prior to the procedure, and you can continue after the procedure. 1200 milligram is the dose. The tablet is available in 600 milligram power, so we can use twice a day for 3 days N-acetylcysteine.
Right. So any of the residents, if you have any query or any comment on the whole lecture, and if you want to know something else, so you are most welcome. In the meantime, I would just ask you, what is the usual prescription of a CKD patient? Because we find that many of these patients would have kind of different kind of therapies given by different nephrologists. So what do you think if the patient is supposed in a early CKD and he has a mild proteinuria? So what would you advise him as a treatment?
So first of all, blood pressure is very important. If the patient is hypertensive, RAS inhibition is advised in these patients. You can use ACE inhibitor or ARB. Many a times these patients are having uncontrolled hypertension, then you have to add the second drug. The second drug, most of the time, it is the calcium channel blocker. If the patient is edematous or there is salt water retention, you can use diuretic. Depending upon the serum creatinine level or GFR, we have various type of diuretic. In early GFR, we can use thiazide type of diuretics. But if the GFR is less or advanced CKD, you have to use the potent diuretics, that is the loop diuretic, either furosemide or torsemide. Then you have to use the phosphate binders. You should look for the calcium, phosphorus, serum IPTH in these patients. So if the phosphorus is high, you have to use the phosphate binders. Nowadays, we use most of the time non-calcemic phosphate binders. As I have told, sevelimer carbonate, it is available in 2 strengths, 400 milligram and 800 milligram. And remember always that phosphate binders should be taken along with meals. It should be ideally taken between meals or immediately after meal, so that it chelates or binds the phosphorus which is there in the meal. Then after phosphate binder, you have to take care of the anemia. For anemia, you should look for the iron studies in this patient. You should establish serum iron, TIBC, serum ferritin. So in all these patients, we should look for serum iron, serum ferritin, and TIBC. even before starting erythropoietin, we should always look for serum iron, TIBC, and ferritin. When and when there is adequate iron stores in the body, then and then erythropoietin will act. If there is iron deficiency and if you will give erythropoietin, it will not act. So first take care of the iron stores in these patients. Nowadays, IV iron therapy is available. We can use IV iron. And remember, if you are giving erythropoietin to these patients, you have to look for control of blood pressure, because many times erythropoietin will lead to rise in blood pressure. It can cause hyperviscosity syndrome. Sometimes it can precipitate seizures. So before starting erythropoietin, look for iron stores, control secondary hyperparathyroidism, because if there is secondary hyperparathyroidism, it will lead to bone marrow fibrosis. And if you are giving erythropoietin, it will not act because it is going to act on the bone marrow. So then control of blood pressure is very important. If the patient is having uncontrolled hypertension, we should first control the blood pressure and then start erythropoietin. So we have taken care of the blood pressure, we have taken care of the calcium phosphorus, then we have looked at the anemia, then we have to take care of the serum IPTH level. Then we have the other drugs. For example, if the patient is having hyperuricemia, you can use febuxostat. Now we have a febuxostat available with us. Then you have allopurinol also for hyperuricemia. And after that, you have to look for the other complications, and you have to check the progression of disease. You have to take care of the weight. You have to guide the patient for his diet and lifestyle modification, cessation of smoking. These are important for that. Then vaccination is very important in CKD patients. These patients should be vaccinated for hepatitis B as early as possible. And then the creation of vascular access is also very important. So timely creation of the native AV fistula is very important in these patients of CKD.
We have one question from in the chat box from Dr. Nachiket. He is probably not getting unmuted. So I will ask, after renal loss, as nephrectomy or partial nephrectomy, is there a role of ACE inhibitors to decrease and prevent proteinuria as a prophylactic measure?
Yes, definitely. As we have mentioned that even obesity leads to the secondary FSGS. So loss of nephrons or partial nephrectomy will lead to hyperfiltration and hypertrophy of the remaining glomeruli. So remaining glomeruli have to get the extra burden. So to check that hyperfiltration, hypertrophy, injury, to check the proteinuria, role of ACE inhibitor ARB is always there. Yes.
So even if the patient doesn't go into CKD or doesn't have a AKI after nephrectomy, you would advise them ACE inhibitor?
Yes,
routinely?
in low dose, yes. In many of our diabetic patients with normal blood pressure, we advise them ACE inhibitor ARB to check the progression of disease, to reduce the proteinuria. Many of our nephrotic patients who are resistant to, say, steroids or steroid-resistant nephrotic syndrome, in those patients also, we add ACE inhibitor ARB to reduce the proteinuria.
Right. So, if you do you have any question? Then many of these prescriptions we find that they write soda bicarbonate tablet in every patient. Is it really advisable, or you would give only if the patient is having symptoms of acidosis?
Yeah, so if there is acidosis, then and then only we should write sodium bicarbonate. We can go for estimation of serum bicarbonate level. So if you see the patients of CKD, broadly we can divide into two categories. One is the glomerular disease, another is the tubulointerstitial disease. So patient of CKD is having chronic glomerulonephritis, or patient of CKD is having chronic tubulointerstitial nephritis. Most of the time in our urology practice, we see the patient of CTIN because of stone disease, because of the obstruction. We get the patient of CTIN or chronic tubulointerstitial nephritis. Clinically also, we can differentiate these two patients. In chronic glomerular disease, you will have more proteinuria, you will have more edema, you will have salt and water retention, you will have hypertension. But if the patient is having CTIN, urine output will be good. Patient may not be having salt and water retention. Patient may be dry. And patient of CTIN will have more acidosis and more anemia because their tubular functions are deranged. And we know that erythropoietin comes from the tubulointerstitial department. We know that the control of H ion is through the tubulointerstitial department. So most of our urological patient will have more anemia and more acidosis. So in these patients, we have to use more sodium bicarbonate, but it's always better to establish serum bicarbonate first and then use sodium bicarbonate.
Right. One more thing which is coming up nowadays is that you have aldosterone antagonists like finerenone or eplerenone. So all these probably they not only reduce the blood pressure but also helps in curing proteinuria. So do you think this should be taken up as upfront therapy before we start the ACE inhibitor or ARB?
So aldosterone antagonist is also a part of, you can say, RAS inhibition, renin, angiotensin, aldosterone axis. So all these drugs, whether it is the ACE inhibitor, ARB, or direct renin inhibitors like L-styrene, or you mentioned the aldosterone receptor blockers. So these are acting on the RAS system. So aldosterone antagonists, now the studies have shown that they check the progression of disease. They are good for the heart also. So they reduce the cardiovascular morbidity and mortality. And many times in our refractory hypertension or resistant hypertension patient, we find that the aldosterone level is high. We say that patient is already on 3 antihypertensive drugs in optimum doses. And out of these 3 drugs, one is a diuretic and still blood pressure is more than 140/90. We label these patients as having resistant hypertension. And many of these resistant hypertension patients, they respond to aldosterone blockade. So aldosterone blockade has definitely got a role in CKD progression. Yes.
Dr. Nachiket is asking which ACE inhibitor is your choice?
So there are so many ACE inhibitors available to us. It is the evidence-based medicine. So we started with, say, using enalapril, then lisinopril, ramipril. So now the evidence is more with, say, the newer ACE inhibitors. So ramipril is my personal choice. Ramipril is good for the heart also. Similarly, in ARBs also, starting from the losartan, then you had telmisartan, then you had irbesartan, now newer sartan, gilsartan, olmesartan, these are all available. So you have the evidence-based medicines. You have the various, you can say, the landmark trials. For losartan, you had the renal trial, which showed that losartan is good for diabetic nephropathy. Then for telmisartan, you had the on-target trial, which compared the telmisartan with ramipril and combination of telmisartan and ramipril. And remember, nowadays, the combination is not preferred. You should not use both ACE inhibitors and ARB in same patient, because the on-target trial showed that if you are combining both drugs, there are more chances of drop in GFR, there are more chances of precipitating AKI, there are more chances of causing AKI. So on-target trial showed the pleiotropic effect of the telmisartan also. There was reduced incidence of new onset diabetes. There was reduced incidence of atrial fibrillation. There was reduced incidence of stroke also. And then for olmesartan, you had the roadmap trial. As I was mentioning that in roadmap, even the diabetic patient who were not hypertensive, their olmesartan was used, and new onset microalbuminuria was less in these patients who were started on olmesartan. So now we have evidence-based medicine, we have various landmark trials, and on the basis of that, you can use these drugs.
Thank you, Dr. Vinay. I think the last question, if you do not have any question from the floor, then we know CKD is a progressive disease, and ultimately it will end up in renal failure. And half of these patients will actually require renal replacement therapy in their lifetime. So what do you think is the research which actually will probably kind of check or stop this progression of the disease? Is there anything in the frontier, in the future, we are going to have some kind of therapy to check the progress of the disease, which we are not doing here?
Yeah, so now there are certain advancements also, but remember the basic principle. Checking the disease as early as possible is very important. So early diagnosis, so a patient of diabetes, control his blood pressure and blood sugar, meticulous control from the very beginning. A patient of stone disease, treat the stone disease from the very beginning. A genetic predisposition, a patient of ADPKD, you know that there is family history, so you should check these diseases as early as possible. But definitely now we are having new advancements, new drugs are there, free radical scavengers are coming, endothelin blockers are coming. For diabetes also, now we are having drugs. We know that transforming growth factor beta is leading to fibrosis. Now we are having drugs to check those fibrosis. We are working on artificial kidney, newer modalities of dialysis, wearable kidneys, then gene therapy. So most of these things will come in future, definitely. Yes.
Thank you, Dr. Vinay, for that enlightening talk on how to check the progression of the disease and what could be the future of CKD. Just for the sake of benefit of the residents and our young urologists, I would like to say that CKD is a disease which has a chronic systemic inflammatory status, and there is an increased oxidative stress in the body, which ultimately what happens, it causes increase in the cytokine level in the body, and that results will affect the renal hemodynamics, glomerular filtration, and the tubular function. And all these actually then result in progressive glomerulosclerosis and tubulointerstitial disease. And there has been a lot of research now going on, and people are like in adult polycystic kidney disease, they have seen that tolvaptan probably helps in checking the disease. Then, as you rightly said about the endothelin receptor antagonist and all that, and even the gene therapy, because it has been seen that some of these genes, which is called clothozine, which influences the aging phenomenon, if can be reduced, can be controlled, then probably you can control this systemic inflammatory response in CKD. And a very important thing which has come up in the last decade is about the human microbiome. And the human microbiome is a very interesting subject. It is said that our microbiome is about 10 times more than the total number of human cells in the body. And the genetic composition of the human microbiome is 300 times more than our own genetic material. So we are more of microorganisms rather than human body. So it is a very interesting subject, and they say that this change in the gut microbiome and the intestinal epithelial barrier damage, which also results in a chronic inflammatory status, and that is causing chronic kidney disease. So the role of probiotics and the change of the gut microbiome and antioxidants, all these are very promising, probably therapeutic modality in the future. So with this, I think we do not have any query. Then I will wrap up the session. Thank you once again, Dr. Vinay Malhotra, for coming to this session. And we had a very nice interaction. And thanks to all the residents and faculty of not only urology department, but also nephrology department, and all the viewers who have joined us on the Zoom and YouTube. Thank you very much, and have a good day.